So regarding the malignant tumors of the small intestine, although their ratio is not very much, when you talk about the isolated organ pathologies or the tumors related to the large intestine, like they account for less than 10% of the tumors of the GIT tract. But obviously, these malignant tumors are important because they can metastasize, and obviously they can develop the end organ failure, and you have to treat them accordingly, and you have to treat them very aggressively. So when you talk about the malignant tumors, we have the adenocarcinomas, we have the carcinoid tumors, and we have the lymphomas, and we have the other mesenchymal tumors. We'll be talking in detail about these tumors one by one, but just giving you the overview about adenocarcinoma. Obviously, when you talk about the epithelium of small intestine, it's columnar epithelium. So every tumor which is arising from the columnar epithelium is the adenocarcinoma, especially the malignant tumors. So these tumors are, most of the time they develop on a background of some pathologies. Like when you talk about the celiac disease or Pettigers, or we talk about the hereditary polyposis, or non-hereditary polyposis, or inflammatory bowel disease. So they have a tendency, because there's a lot of scarring and fibrosis and chronic inflammatory reactions. And we talk multiple times that whenever there is a background of the chronic inflammatory processes, there is, again and again, turnover, and then regeneration, and there's a fibrosis and a scarring, there's a tendency for malignancy. So these adenocarcinomas, when you talk about the division, or when you talk about the part of the intestine which is involved, is most of the time jejunum is commonly involved as compared to the ileum. And the age, or you can say the fourth or fifth decade of the life, is important for the development of these kind of the carcinomas. And the patient can, again, maybe in the early stages the patient remain asymptomatic, but in the later half it's possible the patient present to you with the anemia, small intestinal obstruction, melena, hematomasses, upper GI bleed, and the patient will have a significant history of the weight loss. So obviously these tumors should be properly investigated, and you need to do the triple contrast CT, and you have to go for a PET scan, and you have to go for chest X-ray, and you have to be very vigilant, because most of the time these tumors, when they come into clinical setting, they have been metastasized already. So for the metastatic tumor, obviously you have to put the patient on a chemo and a radiotherapy, and then obviously you have to do a surgical resection as well. So plan accordingly. Regarding the carcinoid tumors, they are basically the kind of tumors in which there are some kind of vasoactive substances are being produced. And when you talk about these tumors like carcinoid, they can lead to the carcinoid syndrome, in which there are multiple symptoms because of the release of the serotonin or bradykinin, prostaglandin, kallikrein, and they can actually lead to the rush of the sympathetic system. And whenever there's a rush to sympathetic system, the patient can have flushing, tachycardia, palpitations, diarrhea. Just like when you talk about the hyperthyroidism, and there are a lot of thyroxine in your blood, and that will obviously stimulate these symptoms, just like the sympathetic activation and palpitations and diarrhea and flushing and all these things. And these carcinoid tumors, they can be anywhere in the small intestine, but most of the time they're involving the appendix. And if you talk about the order, the first is the appendix, then there's the ileum, then the rectum may be involved. And for these carcinoid tumors, resection and obviously the pharmacological therapy is important. Lymphoma is a multi-system disease, okay? Like we know that there's a proper distribution of the lymph nodes, and there are a lot of lymphatic channels throughout the body, and responsible for the drainage of the lymph from the different organs. So we have the B cells and we have the T cells, and they are responsible for a proper immunity. like B cell immunity, which is antibody mediated, and T cell immunity, which is cell related immunity. But sometimes there is over or you can say there is exaggerated response of the immune system, and when you try to investigate such things, there's a possibility that there's a whole lot of increase in the TLC count or WBC count, and when you're doing the peripheral film, you can see the cytological appearance of these tumors. So remember, there can be Hodgkin lymphomas, there can be non-Hodgkin lymphomas, there can be bucket lymphomas. There are multiple types of the lymphomas, and their classification or distribution is beyond scope right now. But you need to remember that when you talk about the when you talk about the lymphomas in a small intestine, maybe possible they can be primary or they can be secondary. There can be multiple lymphomas anywhere in the body as well. And most of the time, these lymphomas in a small intestine, they are the non-Hodgkin lymphomas. And the patient can present to you with a diarrhea and fever, or you can say a pyrexia of the unknown origin. And when you try to investigate, there is the possibility of these lymphoma. There may be possible if it's a multi-system organ disease. Then we know that these lymphomas, they are radiosensitive, and you have to put your patient on a radiological therapy. But sometimes when they're confined, then you have to go for the resection. So if you talk about the mesenchymal tumors, they are obviously originating from the mesenchyme. Okay, so most of the time you have the connective tissue and a mesenchymal hyperplasia, you can say here, as you can see in the histopathological findings. And these are called the gastrointestinal stromal tumors, okay, GIST. This is a mesenchymal origin, and most of the time it's involving the stomach. And then there are some kind of a patient can present to you with these signs and symptoms of anemia, weight loss, hematomasses, melena, and there's a focal, when you do the CT or contrast, triple contrast CT, there's a possibility of mural thickening, and it's important to get rid of these tumors, resect these tumors, because there is again a tendency for malignancy, and then they're not radiosensitive. Okay, one thing you need to remember about these mesenchymal tumors is that they are not radiosensitive, and they're not chemotherapy. They don't have a good chemotherapeutic response. So surgery is the only option for the gastrointestinal tumors. There are some researches going on with the new drugs and new chemotherapeutic agent, but none has been proven otherwise till now. So surgery is the mainstay for the mesenchymal tumors. So remember about the malignant tumors, that you have to treat them aggressively. Early diagnosis is very important, because whenever the tumor is already metastasized, then maybe possible you don't have a margin, or you don't have a lot of time for curative therapy, or curative surgery is not possible, and you just have to put your patient on palliative therapy, or you go for chemo and a radiotherapy. So remember that in carcinomas are most common in jejunum, carcinoid tumors common in the appendix, the ileum, the rectum, and the lymphomas. They can be anywhere. In mesenchymal tumors, they are most of the time involving the stomach as compared to the rest of the GIT part, and surgical resection is the treatment of the choice for the mesenchymal tumors.